Welcome everyone. This is the third installment of the 2009-2010 NYU Reynolds program's Social Entrepreneurship in the 21st Century Speaker Series. My name is Bradley Chin. I'm a 2008 Reynolds Fellow from the School of Medicine. I'm thrilled to be given the opportunity tonight to introduce our guest, who's Mr. Karl Hofmann. He's the President and CEO of Population Services International, and it's also called PSI. You may be wondering why we invited PSI to participate in a series on social entrepreneurship, but I think after tonight, it will become incredibly clear. The NYU Reynolds program defines social entrepreneurship as pattern-breaking work of social importance done in ways that are both sustainable and scalable. Implicit in that definition is the idea that social entrepreneurial efforts require measurable outcomes. PSI truly lives up to this definition. With the slogan of healthy lives, measurable results, PSI strives to improve the health of poor and vulnerable people in the developing world through social marketing of family planning, health products and services, and health communications. Since good prevention is the best cure, PSI focuses on tackling specific problems like dysentery by providing sustainable, clean water to families, HIV transmission via education on safe sex practices and condom usage, and malaria by the distribution of ITNs, or insecticide-treated mosquito nets. Working in the public and private sectors, and also leveraging the power of the marketplace, PSI has been quietly, but very efficiently, saving millions of lives. In 2007 alone, they helped to prevent 19 million cases of malaria, 2.6 million unintended pregnancies, 3.8 million cases of diarrhea, and over 150,000 cases of HIV infection. All of this translates into well over 15 million productive years added to the lives of poor and underserved individuals in over 65 countries around the world. PSI was recently awarded a nearly $1 billion grant from the Global Fund to fight AIDS, tuberculosis, and malaria. They currently have an operating revenue of over $400 million, with over 95% of that going directly to services. Perhaps not surprisingly, GiveWell, a charity review organization, recently called PSI the most efficient saver of lives in sub-Saharan Africa. Mr. Hofmann is also an accomplished diplomat, serving in various roles such as the U.S. Ambassador to Togo, the Executive Secretary of the Department of State, and he was also a member of President Clinton's National Security Council. Mr. Hofmann has won numerous awards for his efforts in disease prevention and health promotion, and has lectured all over the world on ways to help improve the lives of others. He is in every sense of the word, a true social entrepreneur. So please join me in welcoming Mr. Karl Hofmann.
Thanks very much. Can you hear me? Live? Trying the button. How about now? There we go. Thank you, Brad. That was, my mother would have blushed at that introduction, so thank you very much. And many thanks for the invitation to be here, to be part of this really impressive lecture series. As you heard, I'm Karl Hofmann, and for the last 3 years I've been president of PSI. But as Brad mentioned, prior to having the chance to take over this great institution, I was an American diplomat for about 22 years. Served mainly in Africa, started out in the Caribbean, ended up in Europe, and spent most of my time in Africa. And had a wonderful time in that career as well. PSI is a nonprofit social marketing company. We've been around for about 40 years next year. Distributing life-saving products and services using private sector, involved in behavior change communication and the provision of quality services, all designed to improve the lives of poor and vulnerable people in about 65 countries around the world. You would think that somebody at the head of PSI would have a business background, or at least would have a public health background. I like to say that I have 20 years experience trying to market American foreign policy, which wasn't always an easy sell. And so that's been my experience with marketing. But now I'm learning about social marketing. In this terrific series, you've had some really impressive speakers, which is why I'm delighted to be part of the list. And I've listened to a number of them, both from this year, well, I guess you've had two before me this year, and some in previous years, so I've looked at those on the web. And what I think, a number of them have talked about is for-profit models that attempt to achieve a social mission as part of their business model, whether it's through green sourcing or enlightened investing. I would say PSI's model is really the inverse. We start out with a social mission, as you heard, trying to save or improve the lives of poor and vulnerable people. But we apply hard-nosed and really cutthroat business and private sector practices to achieve it. Instead of being social entrepreneurs, I would say we're really entrepreneurial social workers. We're aiming to be the Southwest Airlines of global health. We're aiming to be the Goldman Sachs of global health. Although actually I would say in global health, there isn't really a for-profit or a not-for-profit split any longer. Solutions don't come out of one camp or the other. Our donors, funders in global health, are looking for public-private synergies. And we're being paid to produce health outcomes among target populations. And we're using private sector and private sector-like approaches and disciplines. But we're always working with and for the public sector. So social entrepreneurship in the 21st century for us is about embracing private sector approaches and disciplines to generate social benefit. The PSI story all starts with this, the condom. In 1970, two guys were studying public health in North Carolina. And they thought it was wrong for mail ordering of condoms to be illegal, which it was then. Eventually that law got changed, but at the time it was. And they decided, working with what turned out to be a very profitable market, a very profitable set of consumers, college students, to set up a mail order condom business. And it worked pretty well. Later, they were traveling in South Asia, these two guys, and they noticed what a lot of people had noticed before, that there was a crying need for family planning. And that there was an incredible lack of family planning options for women, men, and couples, mainly simply because there was a lack of access. They understood that if a family isn't able to choose how many children to have or when to have them, that they're pretty much locked into a cycle of poverty. So they did something very simple. They took these condoms and they added to that some trucks. And with money from their condom mail order business, they started selling at subsidized prices condoms throughout South Asia. I'm simplifying a bit, but that's basically what it was at its outset. Two people who noticed a demand and found a way to fill it. And eventually they founded PSI. They kept in mind some core principles that guide us still: a focus on measurement, speed, and efficiency, a belief in the power of markets to reach people in need when the public sector doesn't, and a commitment to the dignity of every human being, particularly poor and vulnerable people, who deserve the same dignity that you and I have when we're treated as consumers, when we're making choices about health care or other options in our lives. So PSI became well known for our ability not just to distribute condoms and other family planning products, but also to influence behavior through marketing disciplines. And when the AIDS crisis appeared, PSI was well placed to tackle the prevention of that disease. Today we operate in more than 60 countries around the world. We continue to work in reproductive health and family planning. And we're at the forefront of HIV prevention efforts worldwide. I asked our folks the other day if they could look into our sales database, which goes back, I think, only to 1987, even though we've been operating for 40 years, to tell me how many condoms PSI had sold or distributed for free over the period since 1987. And it's something north of 14 billion. There's a big market for condoms out there. But not just condoms. I mean, in our HIV work, we're also, I think, leading the way on some groundbreaking prevention initiatives like male circumcision. Sounds like a marketing challenge. Turns out not really to be one. We expanded into other health areas too. In malaria, we're the largest procurer and distributor of mosquito nets in the world, alongside UNICEF. And we now have extensive child survival programs as well that are protecting families and young kids every year from such things as the absurdly simple, absurdly preventable, and absurdly treatable diarrhea, which after all kills the second largest number of kids under 5 in the world every year. Our work is very much about the people we serve, but at the heart of everything we do are numbers. We like metrics, and we work very hard to quantify our impact. And the idea behind that is not to simply measure what we achieve, but also to be honest about what we're not achieving. We do this for every intervention, whether it's for a condom that's sold or distributed, or a mosquito net, or a liter of purified water. The goal is to know exactly what impact we are having and to let that evidence guide our decision making. And to come up with these figures, we use an equation like this. We're essentially taking the burden of disease, multiplying it by the effectiveness of an intervention, and then by the number of units required to treat one episode of a disease or to provide one full year of protection. Now, this gets a little nerdy here, so bear with me. But this is at the essence of our calculus about our profit, our retained earnings. The effectiveness of an intervention always stays the same. The number of units required to treat an episode of disease always stays the same. But the variable factor is the burden of disease. With HIV, for example, the burden of disease in South Africa is considerably different than it would be in, say, Canada. So an intervention will have a greater impact in South Africa than it would in Canada. Or let me give a more concrete example from someplace that I visited just last month, one of our programs in southern Sudan. I was in Juba. And let's look at the example of an intervention which would be an IUD, an intrauterine device. The burden of disease, tragically, in a place like southern Sudan, for the condition of simply being pregnant is 0.25. In other words, there's a 1 in 4 chance that a woman who is pregnant in southern Sudan will die simply as a result of being pregnant, not being able to give birth in a safe way. So burden of disease, 0.25. An IUD is a very effective intervention at preventing pregnancy. In fact, it's considered to be 90% effective. So here the equation would be 0.25 times 0.9. And finally, an IUD is normally good, actually it's good for longer than this, but it's considered generally to be effective for 3 years. So when we talk about the final piece of the equation, it's 1/3. 1/3 of an IUD essentially would be required to achieve a year's worth of protection. So if you multiply those three numbers, 0.25 times 0.9 times 1/3, I think you get 0.75, which means that in southern Sudan, if we were distributing, selling, or providing for free an IUD, and we were sure that it was being properly inserted, that would translate into 0.75 DALYs, 0.75 disability-adjusted life years. Again, this is our core metric of our effectiveness, the DALY. It's a widely used measure that was developed almost 20 or 10 years ago, I guess, by the World Bank and the World Health Organization, originally designed to help health ministries in the developing world decide how to make resource allocation decisions. It combines the years of life lost to death and the years of life spent with disability to give an overall estimate of the burden of disease in terms of the actual lives of people. And we adopted the DALI a couple of years ago to try and standardize a unit of measure across all our areas of intervention to understand how we do vis-a-vis other actors in global health, to make sure we were aligned with the metrics that other actors in global health are using to measure their own efficacy, and to be able to compare across our areas of intervention our cost effectiveness. And basically, adopting this measure has paid off for us. Over the last 10 years, our health impact, measured in DALIs, disability-adjusted life years, has grown. As you can see, it's a nice, pleasant, upward-looking graph, except for that 2007 problem, which unfortunately was the first year of my tenure at PSI. I don't think it had anything to do with me, I hope. These are rates of growth here at the top, and you know, those are healthy. Any private sector company would be pretty happy with that rate of growth in your retained earnings. In 2009, we will have averted something north of 14 million DALIs. In other words, we will have obtained 14 million years of healthy life that would otherwise have been lost to death or disease, but for our interventions. And we're doing that all at a cost of less than $35 per year. So these are, as I mentioned, our retained earnings. This is how we're measuring our profit. This is how we report our year-end results to my board, my boss. This is how we incent, partly, some of our country platform managers, how they do at producing DALIs or averting DALIs. It is really a core unit of measure for how we operate our business. And we've set ourselves some ambitious goals. Over the period 2007 to 2011, we aim to double our health impact, double our DALIs. So by the end of 2011, we should be averting, if we stay on track, around 20 to 21 million years of life that would have otherwise been lost to death or disease every year. Now, how have we gone about doing this? Well, really, for me to describe that further, I need to talk about what we decided to do 40 years ago when we adopted our doctrine, which is social marketing. It's a term that's been controversial in the past. Some people interpret it to simply mean selling products to the poor, profiteering from the misery of the vulnerable and poor. And in some cases, it does make sense to sell, but not all. For us, we've defined it a little more broadly. Social marketing is the application of marketing concepts and techniques and disciplines to influence behavior among a target audience in order to benefit them and society. It should help increase both access to and use of products, behaviors, and services. And there are times when selling products makes sense, or charging for services makes sense, and I'll talk about those. But social marketing also, of course, embraces the concept of free distribution. Just because it's being given away for free doesn't mean it's not being marketed. We're using the same techniques as Coca-Cola, although we're marketing products that we feel truly benefit communities. Another way to look at this, at the sort of position of social marketing, is in the context of what we call the total market approach. There's obviously a space for the private sector everywhere. And when we're talking about health, by the way, for poor and vulnerable populations around the world, it's not the public sector that manages to provide that. It's very largely the private sector from whom poor and vulnerable people are getting their health. So the private sector has a role that it plays, and the public sector has a role that it tries to play. And social marketing is really about bridging the gap between those two for populations for whom the private sector is not interested in serving them, and for whom the public sector is not able to serve them. The total market approach. Like Coca-Cola, social marketing is grounded in the 4 P's of marketing: product, price, place, and promotion. And these 4 P's are grounded by the bottom line. Like any fast-moving consumer goods company, we'll succeed if we know how to get products people need into their hands and convince them to use them. And even when we're not talking about the product P, we're aiming to get consumers to switch their behaviors from a less healthy one to a more healthy one. All of us have experienced this sort of marketing. Seatbelt use, or smoking cessation, or pretty soon texting while driving. Okay, I promise I'll stop doing that. Okay, I promise. But that, we all know what social marketing is like with regard to behaviors. In Kenya, we used this approach to promote abstinence. Kenya had never promoted abstinence on a large scale as an HIV prevention technique, but there was evidence that we saw that indicated it could make a difference. So after doing some marketing research about the best approaches, we launched a campaign called Chill, which is a word in Swahili, designed to target 10 to 14-year-olds, youths in urban areas, with the goal of delaying sexual onset. Let's take a look at how it looks.
No, I'm not ready.
See, not me. I'm too young. Me? No. I know Siwezi. At my age, are you mad?
Forget it. I'm not ready.
No way, not me.
I'm not gonna have sex. I'm too young.
Yeah, me too. I'm gonna chill.
Where chill? To me chill. Nita chill.
Name chill.
Nita chill.
Yeah.
Where chill?
When I was in Kenya last month, I saw that actually on the street. This campaign, again, according to market research, was seen by about 85% of the target youth population. And again, according to market research, the proportion of that group who reported never having sex increased from 88 to 92% during the 7 months of the campaign. Now that doesn't sound like much, 88 to 92. But for a consumer goods company, for a Coca-Cola, a 4% market share swing would be huge. We look at this as market share, much as Coke would. Only in our example, the alternative isn't Pepsi, the alternative is risky sex or premature sex. Social marketing goes beyond mass media of this sort, obviously. It also requires individual interpersonal communication, and sometimes a person's personal advocacy can be the most effective way to reach a target group or to break down barriers or stigma. This is a guy named Davies Lazodze. He's from Zimbabwe. He works with our program in Zimbabwe. He was a high school lecturer who contracted HIV, but like many people in Zimbabwe, or many other countries around the world for that matter, he hid his status. He was stigmatized and he was ashamed. But he finally got tested and learned that he could live positively. So among PSI's activities in Zimbabwe is voluntary counseling and testing for HIV prevention. Through franchised VCT clinics, centers, that are branded as New Start. That's our brand there. But the best high quality VCT services won't do you any good unless you can create demand. Again, it's a marketing challenge. So Davies was hired by PSI as a champion for demand creation around VCT. He came to Washington a couple of months ago and was in my office, and we talked about his experience as a PSI employee. And I wrote it down because, you know, it was simple but profound. He said Zimbabwe had never had professionals such as me coming out publicly, even though the HIV burden in Zimbabwe is substantial. But professionals were not out describing their HIV status in public. So, being a professional myself, he said, PSI took me on, and that gave real meaning to the anti-stigma campaign. In Zimbabwe, people have now started to respect that HIV doesn't affect one particular stratum of society, but it cuts across the entire society. PSI is running behavior change programs, HIV and AIDS prevention programs, so I go there to PSI to use my experience as a role model, as someone who's positively living with the virus. So thanks to the efforts of people like Davies, and with a quality offering in terms of VCT services, PSI Zimbabwe recently tested its 1 millionth VCT client. So staying within the field of HIV prevention, you can see how we grew up learning how to be a product company, and then expanded into behavior change communication. And now we're trying to move further into quality service delivery. I mentioned male circumcision. Male circumcision has been shown in randomized controlled trials in Africa to be as effective a brake on HIV transmission as any vaccine is ever likely to be. We, using some of our own resources, piloted a small male circumcision activity in Zambia because we thought this was a terrific skill set that we had to master. We shared some of our experiences at the International AIDS Conference in Mexico City last year. And eventually we won some funding from the Bill and Melinda Gates Foundation to take our programs to scale in Zambia and in Swaziland. In fact, we're also doing this in Namibia and South Africa and Zimbabwe, and talking about scaling up further in Southern Africa. We've just sort of set up an internal little mini venture capital fund to try and incent our field programs to come up with new programs to pilot male circumcision activities, $1.5 million. We'll see how far we get. So, you know, this is about safe, quality clinical services. It's about behavior change communication. It's about communication around safe post-operative sexual behavior, because there's a risk with male circumcision that it may be seen by some as sort of a perma-condom, when in point of fact, for a period after the procedure, there's in fact a greater risk of transmission. So you've got to be communicating about safe and correct and consistent condom use. So there's a whole, it's all wrapped in a group of interventions that have to make sense. But all of those things together, our products, our behaviors, our services, again, going back to our DALI model, in 2008 added up to about 3 million years of healthy life that would otherwise have been lost to HIV. And the bulk of this work for us is occurring in the high burden countries, South Africa, Zimbabwe, Nigeria, Mozambique. But we also have HIV prevention programs in about 30 other countries. That's the HIV story for us so far. You'll notice it's not involved treatment. We are all about prevention. That's not to say that there isn't tremendous need for treatment as well, and a lot of organizations doing great work in treatment, and a lot of resources going into treatment. But for every individual put on treatment, there are still 6 or 7 new infections in the world. So the prevention challenge is still tremendous, and that's where we've put the bulk of our effort. Products, behavior change communication, quality services, scaled up to provide access, dignity, and choice to our target populations, our target consumers, our target market. So I've talked a lot about HIV so far because that's where we've really learned a lot of these skills and also learned a lot of our lessons, what not to do. We've learned better how to manage the product side of our work, the BCC, behavior change side, the services side, and now we're applying those lessons across different health areas, although it's not always exactly the same or quite as easy. For example, as Brad mentioned, we are a leading provider of mosquito nets. I think in 2010, our mosquito net distribution will total finally more than 100 million nets. The Global Fund for AIDS, Tuberculosis, and Malaria uses PSI as one of their 2 procurement agents, essentially. In fact, I believe we're the only procurement agent that the Global Fund uses to procure mosquito nets for all of the malaria programs that the Global Fund funds. Those using PSI and those not using PSI, we're their procurers. Because it turns out that those 2 guys with the truck and the condoms 40 years ago, who started to master the skill set of how do you procure a product, how do you store it, how do you account for it, how do you distribute it, how do you get it into the hands of people who will use it, that skill set is a very potent skill set in global health. It's the ability to move stuff to consumers who need it. You have to do it in a lot of different ways. You know, we've used hovercraft to move mosquito nets. We've used donkeys to move mosquito nets. We've used bicycles. We've used trucks, obviously. In the past, our experience was really around social marketing these nets, which meant using the private sector and distributing them at a subsidized price. But over the last couple of years, the global malaria community has really put huge resources into the effort to drive the burden of this disease down in Africa. And there are a lot of large ambitions around this now. And this combination of huge resources and great ambition in global health to really drive the malaria burden down means you can't just go about socially marketing nets. You've got to do mass distribution campaigns, free net distributions. And because we have supply chain management and distribution and logistics capabilities, we've turned out to be pretty good at that too. And in fact, we're doing mostly that now. From a company that went originally to selling all of our output at subsidized prices, right now about 50% of our impact, 50% of our DALIs, 50% of those 14 million DALIs or so this year are going to come from things we give away. It doesn't mean we think we're not marketers. It doesn't mean we think we're not using social marketing. We are. But the price in that particular equation is 0. You know, and these things are working. The application of huge amounts of resources really can make a difference. I was also last month in Rwanda. I had lived 25 years ago in Rwanda as a diplomat. That was my second foreign service post. And all of you know the tragic story of that country, the amazing and tragic story of Rwanda. So for me to go back after 25 years was pretty moving. And the country is almost unrecognizable. It's really changed a lot. But one of the ways in which it has made tremendous progress is in malaria. 5 years ago, malaria was the leading cause of death in Rwanda. And Rwanda's, you know, a landlocked country. It's about the size of Massachusetts or Maryland. It's surrounded by some of the most heavily burdened malaria areas in the world. Prior to 2005, a grand total of 30,000 mosquito nets had been distributed by the national government. But that year, Rwanda got its first grant from the Global Fund for AIDS, tuberculosis, and malaria. And that next year, 2006, PSI helped the government of Rwanda deliver 1.4 million long-lasting insecticide-treated mosquito nets to pregnant women and women who had just given birth. That was coupled with programs for home-based management of fever and a whole new cadre that the government put in place of trained community health care workers. We helped with behavior change communication programs, including things like mobile video units, mobile cinemas, to educate people in the most remote parts of the country about net use and malaria transmission. And today, the result is truly amazing. I mean, Rwanda has seen a 60% reduction in deaths due to malaria. And now, in Rwandan health centers, only about 10% of patients are seeking treatment for malaria. By the way, I should say the reason why mosquito nets work so well as malaria prevention, as many of you probably know, and most of you probably know, the mosquitoes that are going to give you malaria are only going to bite you at night. So if you can get your child, in particular, under 5, under that mosquito net at night, you have a dramatically improved chance of avoiding cases of malaria for your child. And malaria is the third largest killer of kids under 5 in the world. So it's a great story. And Rwanda is not the only place where this is happening. Malaria has been, I think, eradicated from Zanzibar, an island off the coast of Tanzania. We have the ambition, the Global Fund has the ambition, and we as their partner, to once again, unfortunately, eradicate malaria from Haiti. And there are other parts of the world where the burden of disease is really coming down dramatically. So, you know, these things do work. But we know, I think as marketers, we also know as human beings that this level of effort and this level of financial commitment probably can't be sustained. Which is why you can't ever walk away from and lose your ability to use the private sector and social marketing through subsidized sale as an effective channel of distribution. The appetite for huge sums of money to drive down the burden of disease like malaria with free mosquito nets will only go so far. And funders in global health will eventually run out of patience. You've got to be, and the nets, by the way, will also wear out. After 3 to 5 years, these nets will wear out. So you've got to be able to sustain that through the private sector social marketing model. And there are other examples of places where that private sector approach, if you don't lose it, can still really achieve great benefits. In Haiti, for example, we've got a miracle, life-saving, ridiculously simple and cheap product. You know, it's not ours, a lot of people use it, oral rehydration salts. These actually now combined with zinc, as the latest evidence indicates, are really effective at treating childhood cases of diarrhea coming from waterborne illnesses. And if not treated, in many cases, this will kill a child from simple dehydration. It's absurd, it's pathetic, it's criminal, particularly because this is a very cheap intervention. But it's also, let's be honest, not very sexy. And there is not a lot of money that goes in to prevent childhood deaths from waterborne diseases. So PSI Haiti has a product called C'est la Vie. This is Creole, obviously, you know, life salt. It's oral rehydration salts. It's been used for so many years that there is a demand for it, even among the poorest and most vulnerable populations. And small kiosks like this one still come to us and demand to stock it because their clients are asking for it. So we're maintaining an ORS distribution program in Haiti that is completely cost recovery. It's using the private sector, it's getting this life-saving product out into the hands of people who need it, and there's no donor funding involved at all. By the way, Ponte is our condom in Haiti. So obviously this guy, whoever this small retailer is making available C'est la Vie as well as Ponte condoms. So what's next for us? You know, we've become, I think, a leader in malaria prevention, HIV prevention, child survival, family planning, reproductive health. We started out as this nonprofit marketing company, and we made ourselves also into behavior change communicators and into quality service deliverers. We're delivering a year of healthy life to our target population that would have otherwise been lost to death or disease at a cost to our funders of less than $35 a year. And we're recovering more than 15% of our costs from the marketing of some of our products and services, and plowing that straight back into our programs to extend them. Where do we go from here? Well, let me take you back to that total market approach comment that I made earlier, and just describe sort of where I think the next several years for us are in the HIV prevention market in Cambodia, another place where we work. In 2007, the market looked, for condoms in Cambodia, looked something like this. Private sector, very small at the top. Public sector, very small at the bottom. Social marketing sector, which is our condom brands, the preponderance of this market. By the way, this is in a country that, through its 100% usage policy, has driven down the rate of HIV infection to something like a prevalence rate of something like 0.6%. So it's a success story. But how do you sustain that? You can't just keep assuming that you can forever run a situation like this, because this is, after all, requiring donor funding of some sort. The market is totally dependent, or largely dependent, on money that's not coming from consumers. We don't see that as sustainable, either from a health nor from a funding perspective. So, we have ambitions now to, over the next 5 years, take the market in this direction. And this sort of represents a future business model for us. Public sector is still here, hopefully more efficient with our help at reaching people who really are the most vulnerable or the least able to otherwise access something as simple as a condom. Private sector, selling their brands at their cost recovery rates, high market stuff at the top end of the market. And then we are segmenting our part, taking our 2 brands there, which are called OK and Number One. I can't remember which one's going to become the cost recovery brand, but one of those graduates to the part of the market, because any market is like this. There's an ability to pay that varies all along this spectrum. And you want to ensure that your subsidy is really only reaching those who require the subsidy in order to use the product or adopt the behavior. And so the idea is you grow the market, you reduce the subsidy, you increase the place for the private sector to play its role, and you sharpen the role of the public sector to make sure they are reaching those who are truly in need. That's an example of how we should be evolving our social marketing doctrine in all the places where we work. I would say, in terms of challenges for us as a company, there's sort of 2 sets. The first, I would say, is programmatic. This is a map of all the places where we work right now. The programmatic challenge is, you've heard me talk about HIV, I've talked about malaria. You're probably familiar with PEPFAR, the President's Emergency Program for AIDS Relief. You may know about the President's Malaria Initiative. These are, as they are famously referred to, siloed, stovepiped, vertical funding streams. Huge amounts of money that have made a great difference in global health over the past, really, 5 to 8 years. But they're stovepiped. And the challenge for funders and for implementers like us and for everybody who's active in global health is, how do you come up with a more integrated model, a more horizontal model that's not so vertical in terms of its funding? Because it turns out that to really have an effect against the burden of disease, you've got to have a much more integrated approach at the country level. People who are suffering, people who represent that burden of disease in all the countries where we work, don't tend to be living in silos. They tend to be co-burdened. They tend to be suffering from multiple health problems. They tend to be suffering from or require multiple interventions. In fact, the burden of disease is concentrated probably in a relatively small group of kids or young people or adults, not the entire population. And if you can get at those people with integrated services, then you can really drive the burden of disease down. But we're not really set up to do that yet because our funders are not set up to do that yet. So that's a challenge, a programmatic challenge, I think, in global health. I think institutionally, the other great challenge that a company like PSI has is, we grew up over 40 years, headquartered in Washington, D.C., operating in 60 countries now, really as a set of almost branch offices, a hub and spoke system. But again, our funders and our host governments, the public sectors with which we work in all of these countries, really are not so excited about funding the work of an international NGO. They want to fund a local organization. They would like local ownership of this sort of effort. And turning ourselves from a fairly centralized company with operating locations in 65 places to more of a network with greater local ownership at the periphery of our operations everywhere, but yet still maintaining rigor in terms of research, discipline, and methodology, in terms of financial management, in terms of our brand promise. This is a real challenge. It's a challenge. How do we let that centrifugal force in our network really go? Because that's what our funders and that's what our hosts want, but yet we maintain enough control to be able to deliver quality output at scale. And that's an institutional challenge for us, and we're wrestling with it. At the end of the day, we can't do any of this without people. We have an international staff, as we call them, of about 300 people, some of whom are manning our programs, managing our programs in these 60 countries. They're expatriating themselves. They're moving sort of every 3 to 5 years between programs or back to Washington. And then we have about 8,000 local employees in all of our different operating environments. Our international staff come from all sorts of different backgrounds: marketers, public health specialists, people who used to sell toothpaste, people who used to sell Coca-Cola, people who used to sell American foreign policy. Backgrounds from all across the waterfront, and probably representing the kind of people who are in this room. It's a great challenge to be managing in a complex environment where you've got the institutional imperative that I just described, how to manage local requirements. You've got corporate requirements in terms of the value of our brand. You're operating as fast as you possibly can and spending money as fast and cost effectively as you possibly can. Because in our business, the faster you spend money, the more lives you save. So it's a terrific challenge to have. And did I mention that we're still hiring? So www.psi.org. I would say, just to conclude before we go to questions, it's a terrific privilege for me to be working with an organization and in an environment where I get to be proud of what we do, everything that we do, and everywhere we do it every day. So thanks very much for letting me share this with you. And I'm happy to take questions.
And we have 2 microphones floating around. One's over there and one's over there. One's on the right, one's on the left there.
There has been some controversy. Thank you very much for your presentation. One question I have is there's been some controversy about free bed nets versus nets for some cost, and if there's no cost connected, there's less uptake in usage. And I was wondering what your experience was on that.
Yeah, there's been a lot of study about that. And as I mentioned, for a long time, we have experience having sold at subsidized prices mosquito nets, which really was the only applicable model when there wasn't huge amounts of funding. Now that there is huge amounts of funding, and there's a lot of research that seems to, an emerging body of research and consensus around the idea that because a mosquito net, unlike a condom or even a safe water solution, a mosquito net is sort of a durable good and a relatively expensive good for poor and vulnerable people, that if there's any cost associated with it, you're going to drive down usage. So there's a strong argument now in terms of equity for giving these things away for free. The problem is you can't do that forever, or you're unlikely to be able to do that forever. So how do you build in the ability to keep up? The global malaria community talks in terms of catch up, keep up. Catch up meaning get all these kids under 5 under a net as fast as we can. But then keep up in terms of what do you do when the nets get torn? What do you do when the nets need to be replaced? Where can the mother go when the mass distribution campaign isn't underway to get a net? And that the keep up part of it often involves social marketing at a price. Yes.
Hello. It's come a topic of concern about condom usage, and in some countries, in articles I've read, they pinpoint India, for example, not only marketing condoms, but having the consumer purchase the right size of condoms and how that can either not lead to incorrect usage, which defies the whole purpose. I'm wondering if PSI has thought about marketing or how to get people to buy the right size, whether it's too large or too small, has been a health concern in some countries.
Well, I think it's a good question. I mean, as marketers, you have to be interested in what your consumers want, and that requires some market research. And it is, attributes like size or smell, or packaging, or ribbing, or all sorts of other attributes that can apply to condoms have to be part of your toolkit as you try and figure out how to maximize correct and consistent use. You want, segmenting the market, because the condom market, the consumer is not, if you go into the drugstore and look at the brands that are available of condoms in the United States, there's a wide variety of brands. If you go down the cereal aisle, there's a wide variety of cereal brands. The market is finely segmented, and it's a mistake to assume, I think you're absolutely right, that the poor and vulnerable consumer is simply going to take what he or she is given and use that product. No, you've got to treat that person as a consumer, and size and other attributes have to be the subject of the sort of market research that should allow you to put the right product into that person's hands. So we do that in all of our different places, and so we have all these different brands. The first aspect of how you sort of individualize your condom work is, what's a brand that makes sense? What's a brand that has meaning in a local context in country A that wouldn't necessarily sell in country B? In some parts of the world, that brand may be very sexy. It may be very oriented toward young, sexually active adults. In another part of the world, it may be more appropriate to market a condom primarily as a birth-spacing family planning product. And there, it's not about a sexy marketing campaign. It's a completely different approach. So you have to be able to do all of that if your goal is to drive usage as high as you can.
So would this be on the package itself, kind of arranged? I think of women's tights. They have the height and the weight. And,
I should have brought some condoms, some condom packages. Yeah, they all.
Thank you.
Yes, they do. By the way, we also market female condoms and distribute female condoms.
Hi. This may be an overly broad question. I'll try to put it in kind of business terms. So you are entrepreneurial social workers. And what I wanted to ask is about your product portfolio. How do you decide, what's the next product into which you're going to diversify? And kind of a second portion, do you face any legal or regulatory problems or maybe some backlash from governments, and how would you deal with that if you think this product is really worth to the market?
That's two great questions. We just actually had a sort of a senior staff offsite where we tried to do some thinking, some over the horizon thinking about where our future health impact should come from. And we have debated in the past, social marketing isn't unique to health, obviously. You can socially market all sorts of things. Things that would involve income generation, or things that might be related to education. Should we limit ourselves to health? We ask ourselves that. So far, we have kept ourselves within health. What should be our future products? We don't really know. I think a lot of our work has involved preventable diseases and infectious diseases. The burden of disease around the world in a lot of places would dictate that we should be a lot more involved with chronic diseases. Things that are the result of obesity, or things like diabetes. These really are much greater burdens on the health of populations in certain parts of the world. But, and here is a key problem for any organization like us, at the end of the day, we are largely dancing to the tune called by our funders. And there are huge amounts of money available for HIV. There are huge amounts of money available for malaria. There are not huge amounts of money available for obesity reduction. or prevention among adolescents. There are not huge amounts of money available for even oral rehydration salts and simple products that do fit within our skill set. So, you know, we try and respond to the market, but at the end of the day, we have to identify funding. And donors, educating donors and bringing donors along to where we think they should be is a risky proposition for anybody who relies on donors. So, you know, it's a dance that we do. Your second question about whether we get in trouble or face regulatory or political hurdles, absolutely we do. I mean, as you can see, a lot of our work, you know, starting out with family planning and certainly right through HIV involves one of the most sensitive topics for any society anywhere, which is sex. And that can get you in trouble if you're not really careful about how you approach it and really careful about with whom you work and what sort of steps you take to ensure that you're staying within sort of social norms wherever you're operating. But when you're trying to make a difference with HIV, you've got to deal with the most at-risk populations. You've got to deal with men who have sex with men. You've got to deal with injecting drug users. You've got to deal with commercial sex workers. These are populations that by definition are on the margins of society, stigmatized, or it's illegal, or they're certainly, you know, not embraced by the society. And that's true here to some degree. So, you know, how do we navigate through that? I guess with a little bit of diplomacy and some skill and making sure you're touching the right bases with, you know, all the stakeholders in the country where you're operating. And I would say just to conclude on that question, I mean, we've certainly gotten in trouble in the past in the United States for being as heavily associated as we have been with condoms and with HIV prevention work, but specifically with condoms. You know, one organization's effort to increase knowledge and awareness among commercial sex workers about safe use of condoms is, for somebody else who may be a critic of condoms and sex work, anathema. And we've had serious political problems in the United States at various times in the past, and you can guess when. So, but hopefully we don't now. Yeah, it's a good question. Prepackaged therapy, whether for STDs, sexually transmitted diseases, or for things like treatment of malaria. You face, in different environments, you face different burdens and different hurdles. I mean, you may face a regulatory problem because you're trying to get something like prepackaged therapy into, you know, as far down the medical chain as you can, so that it's closest to the consumer. And that sometimes faces problems from regulatory authorities who would rather that these things be distributed either only through pharmacies or only in hospitals or clinics. And so sometimes you have to test the boundaries of that. You know, you face, anytime you're talking about treatment, you face a challenge, particularly in the environments where we work, of proper diagnosis and ensuring that, you know, you're getting the target population in, getting them properly diagnosed, and then that you have proper follow-up with them. And that's a heavy administrative burden, and it's a pretty expensive intervention to ensure that you're doing that. So I would say those are sort of the challenges that we face. I'm not holding the mic, so.
I was wondering whether you could use your marketing skills to make chronic diseases or non-communicable diseases more appealing to funders or donors.
Well, I think you're right. I think we should. But again, as I said, it's a risky, delicate dance to try and educate your donors. Your donors tend not to want to be educated, whether they are governments or foundations or international organizations. You know, they either exist with a mandate, which is not does not allow for a change in their mission, or they're convinced for political or ideological reasons of what they want to fund. I think the way you educate a donor or a funder potentially is to pilot something and show that you can have a cost-effective impact. I think we did that, for example, with male circumcision. which the US government is only now beginning to think about funding. The Gates Foundation was really reluctant to fund. We knew that it was really important to do that, so we put some of our own money into it. For that reason, for instance, we've taken some of our money and tried to do a pilot program to reduce adolescent obesity in Mexico, because that's such a driver of chronic disease burden later on in life. Now that's hard. It's hard to do. It's hard to measure the effectiveness of it and the impact of it. Because we're talking about behavior change communication. It's really hard to measure in the same way that you measure the volume of products that you're moving. But we're trying it. We're trying it.
Hi. I'm Liz, and I've been a fundraiser for nonprofits for 20 plus years, including some international development organizations, and I've served on the board as well. And we've struggled a lot to come up with ways to calculate the impact that we are making. And my question to you is, where did you learn about these DALI measurements? I know you said the World Bank, but is there a class, or are you open to sharing these kinds of?
Yes, absolutely.
Yeah.
I mean, we have a totally open source approach to this. You know, this was a highly simplified, because I'm not sure I'm qualified to really explain all the intricacies in the formulas. But
well, it'd be different for every nonprofit because they focus on different.
Well, yeah, but you'd hope that, well, if you're working in the same sector, you hope that you're using common metrics. The idea is you should be able to compare cost effectiveness across, you know, interventions, and you need the same set of metrics to do that. The way we calculate our DALIs, by the way, you know, we have a research and metrics staff. We have some outside consultants that have built our DALI models that involve a lot of assumptions when we aren't sure about burdens or efficacy or what's the right dosage. But all of those are externally reviewed, and all of those are completely public on our website. Our goal is to have as many people as possible adopt the same methodology.
Are you involved with Interaction and there's other groups that
We
try
are
to
not a
share
member of
best practices?
Interaction. We've thought about being a member of Interaction.
They'll let you join for free for a year.
Well,
Yeah.
not us.
Not you.
We got too much money, unfortunately. But there is something at the University of Washington, I think, called the Center for International Health Metrics, or Center for Health Metrics Evaluation, something like that. Chris Murray, exactly. And he's aware of what we've done with DALIs. They're, I think, intrigued with our approach to DALIs. They're a place that's sort of a clearinghouse for that sort of information about health, at least.
Okay, thank you.
Yeah.
I have a quick question about your target markets. What's up with Paraguay?
Sort of an outlier, isn't it? Yes.
Yes. So I lived in Guyana and actually worked in an area where 3 out of 4 people have malaria. So I was curious, and Guyana is far poorer than Paraguay. Not that you need to defend it. I'm just curious. What is the rationale for Paraguay? What are you doing there?
You know, it's not, obviously, again, we're going where donors will pay us to go. In fact, in Paraguay, we have no donors. So Paraguay, we're operating simply on a cost recovery basis. And it's a weak, it's not weak, I mean, it's a fairly, it produces a relatively small part of our total global output. But it requires no input from us. It's just churning over based on the availability of products. And it plows its resources back into its own business, so it runs as a business, essentially. We did have an operation in Guyana at one point. I think we must have lost funding. It was before my time. Okay. You know, South America. Why is the map so blank? Well, largely because this is our bread and butter. This is our target audience here, and the economies are that much more developed, and there are that many fewer poor and vulnerable people, I guess, by our definitions. For social marketing, the social marketing model doesn't work that well. Plus, there's less donor money there.
I was just going to, having worked in South America for a total of 6 years, that's our big challenge. Is most of the money in the last 10 years has shifted further to the next continent, which is far more in need, and I can't argue against that.
Right.
I'm very curious about the Guyana and Paraguay thing.
Yeah.
Okay, thank you.
I grant you that.
I was fortunate enough to collaborate with PSI when I was in Peace Corps Togo.
Oh.
Yeah, Togo. And they had started a small kind of pilot program there in Lomé, working with MSM and HIV prevention.
Yes.
I was wondering if there are any other similar programs in other African countries or anywhere else in the developing world.
It's a great question. The MSM program that we have in Togo is still sort of our, I don't know if it's our flagship program, but it's where we started doing that work first. And I don't have to tell you, since you were there, it's a very tough group to try and make inroads with and to work with, because there's so much stigma associated with it, and sometimes criminalization associated with it. So we're trying to do that in a number of other countries in Africa. And it's pretty clear from the latest data available from experts at the World Bank and elsewhere that MSM populations and injecting drug user populations are really where the epidemic is still flowering. In most of the other at-risk groups, the global HIV control world has its arms around the problem, but not with MSM and not with IDU populations. So we do some work with IDU in Southeast Asia and in Central Asia, where that's a big driver of the epidemic. Although increasingly also supposedly in East Africa that's a problem, as the global heroin trade sort of makes its way through all sorts of different parts of the world. IDU use follows, HIV follows. Anyway, we're working on it. But I'm glad where were you posted in Togo?
I was near Anye, a small village called Badike. But actually a friend and colleague of mine is still working in Togo, stayed on after Peace Corps, and is doing a lot of work with the MSM program, and they're doing really wonderful things there.
Is it a guy?
Yeah.
What's his name?
Ben Clapper.
Yeah, I met him. Yeah, he's doing well.
So why Togo with the MSM? Then why not South America?
Togo has an odd mystical connection to PSI. I've got, Togo runs through me. There are a lot of former Peace Corps volunteers who were Togo volunteers who now work at PSI. I don't know why.
So maybe I have hope to get a job there.
Maybe. Absolutely.
This may be going too far afield, but I guess I was just curious. I know that obviously much of your perspective on the behavioral changes through the social marketing, but I know because I work with an international organization, and clearly in terms of sustainability, it seems like there's also kind of a cultural shift, political cultural shift in the communities or the cultures that you're working in. So I was just curious if you think about engaging that more broadly than the social marketing, so
Yes.
how, or if you work with it, and just more about how you work with that.
Yeah, no, that's a good question. I mean, social marketing may tend to falsely imply that there's a really narrow way to go about behavior change communication. When you're talking about sexual behavior, for instance, of course, as I mentioned earlier, it's very hard to change. Maybe it's almost impossible to change behaviors around sexual behaviors. And if you have the ambition to do that, you've got to work at all different levels. You've got to work with community leaders. You've got to work with religious leaders. You've got to work with political leaders. I mean, where early on in the HIV epidemic, it's not so much the case anymore, but draw the contrast between Uganda, for example, and South Africa. I mean, early in the HIV epidemic, you had this tremendous leadership in Uganda around behavior change at the top political level, from the president on down. The so-called zero grazing policy, which was all about reducing multiple concurrent partnering, which is another real driver of the epidemic in sub-Saharan Africa. And you contrast, and Uganda saw tremendous results as a result of that, downward pressure or downward movement of prevalence. And in South Africa, where there was just an absence of leadership, almost just painful absence of political leadership on HIV, which is only now changing. and you see the result. So, you know, you've got to be operating almost at the head of state level, and you've got to be operating at the church leader or imam level, and you've got to be operating at the community group level, and everywhere in between, if you really have ambitions to change social behavior around things like multiple concurrent partnering. It's hard. We're trying it, but it's hard.
So this is going to be our last question.
Hey, I just wanted to know if you could go a little more into detail about how you plan on sort of giving control over to the network, the hubs of the organization.
Yeah, well, I'm not sure I want to give control over. I want to give the semblance of control. I want each of our platforms, as we call them, to be more locally grounded, to have deeper local roots, to have more of a local face and a local identity. But I still want them to be part of PSI. And I still want them to want to be part of PSI. In those 60 countries where we operate or so, there are two places where our operations, and two places where we get a lot of our health impact, a lot of our DALIs, but where we don't control the operations. One is in Nigeria, and one is in Pakistan. And in those two countries, there are local non-governmental organizations that are in which we are sort of a minority partner. I sit on the board of something called Green Star Social Marketing in Pakistan. And PSI was the founding sort of spirit behind Green Star. But Green Star is independently governed from us. And although we have international staff there, and we count their health impact as part of our total health impact, and some of their money comes through PSI, some of it comes directly to them, and they're independent from us, technically. Same is true in Nigeria. My deputy at PSI sits on the board of the Society for Family Health in Nigeria, which is our affiliate there, our partner. So those are two places where we don't exercise control. We exercise influence, and I think we have an organic relationship with those two entities, which are really important players in big, significant countries with big global health missions. Do we want to do that everywhere else where we operate? Not necessarily. In other parts of the world, we couldn't turn over our operations in the Congo to a local NGO because I think there just isn't the institutional capacity there to play that sort of a role. Although in the Congo, we're called also the Society for Family Health, and we have a local board that is partly Congolese, but partly PSI, and PSI still controls that board. So I look at it as a spectrum. We've got to be comfortable operating all along a spectrum. But everywhere we operate, we have to be sensitive to the desire that we have a more local face and a more local identity. And check with me in 5 years and see how we've done. Anyway, thank you very much. Good questions.